think they are running very much behind schedule. We'll close this session. If there are any further questions, people, the delegates are free to ask during the tea session or the tea break. I thank all the speakers for a very wonderful session, and at the end it was also very interactive and informative. Thank you very much.
Thank you, distinguished delegates, for that invigorating display of neurological knowledge and discussion. Since we're running low on time, we will be doing our felicitation after the immediate session that follows.
Ladies and gentlemen, we will be starting our next session exactly at 11 a.m. and we have your tea with us, so it will be circulated at your respected places. Please do not go anywhere. We will start exactly at 11 a.m.
We repeat, please remain at your seats for our next session. We are going to have our international guest with us at precisely 11 a.m. Again, please remain at your seats. Ladies and gentlemen, as the sun climbs higher over the Ghats of Varanasi, we gather here for one of the most revered moments of the conference, the P.S. Singhal Oration.
This session celebrates brilliance of neurologists who have transformed lives through vision and research. We are deeply honored to welcome our esteemed chairperson, Dr. Sangeeta Rawat, to come on stage and kickstart yet another interesting session.
The P.S. Singhal Oration. Thank you.
Well, it's here. Nice to meet you.
Good morning, everyone, and I welcome all of you to this Dr. Singhal's oration. Unfortunately, Dr. Antel could not make it due to some visa problems, but he has sent the recorded version, and I'll request my co-chairperson Lakshmi to introduce him, and Dr. Dr. Singhal both are going to join us on the Zoom link.
Good morning, everybody. It gives me immense pleasure and honor to introduce Professor Jack Antel. Jack Antel is a professor in the Department of Neurology and Neurosurgery in the McGill University, Montreal. He has 492 publications in neurology and neuroimmunology in multiple sclerosis areas. Doyen in the field of multiple sclerosis. It is appropriate and very apt that he gives the oration of Professor B.S. Singhal, who is the father of, I would call him as the father of neuroimmunology in the country. And it is absolutely appropriate that such a giant in the field of neuroimmunology is giving the oration to honor another giant in the field of neuroimmunology. Thank you so much, and looking forward to the excellent talk. Thank you. It's a whole my day.
Thank you to the Indian Academy of Neurology for inviting me to present the Professor's Singhal oration. It is particularly meaningful to me because I've known Professor Singhal for many years. I've had the pleasure to meet with him and enjoy both a professional and personal relationship with him. So thank you very much. I apologize that I cannot join you because of complications that arose from issues related to visa and to travel. I was in India in 1995 and enjoyed the reception offered to me by Professor Singhal. And indeed, my lecture today, in fact, goes forward from what we knew back then with regard to multiple sclerosis and how we are taking advantage of observations from the clinic, from basic science, from therapeutics, so as we move forward and we can do even better with our clinical care of patients who suffer from this disease. So I've chosen as the title how past lessons are guiding the future of clinical care in multiple sclerosis. And we can go all the way back to the time of Charcot, the famous French neurologist, who was the one who defined multiple sclerosis as a clinical pathologic entity. It's of interest that at that time, Charcot said, the time has not yet come when such a subject can be seriously considered when talking about were there opportunities for the therapy of MS. And remarkably, it took for more than 100 years until we moved into the therapeutic era of multiple sclerosis. The International Federation of Multiple Sclerosis Societies back in the 1980s and 90s put together a book where they tried to summarize therapeutic attempts that went on until that era. And as you can see from this slide, people had multiple ideas about the cause of MS, from allergies to vascular to vitamin deficiencies, and seemed to carry out trials of very small numbers of people with no objective criteria or uniform criteria, with the claim of improvement that even to this day would far exceed what we've achieved with progressive MS. And it points out that we had to reach the time where we could carry out trials based on solid scientific information and using methodologies that could be reproduced. And also on this slide is showing what I've referred to as the modern era. You can see that it was only that in the last 20 to 30 years that we've moved into the therapeutic era in a way that we can all understand. So, in fact, when I visited India in 1995, we had barely moved into any therapeutic effective therapy of MS, and remarkably, what have we learned since then? If we move back to the pre-treatment era, that this was the way that we looked at MS prior to the advent of the new diagnostic and diagnostic materials that we had. And what we did in those days with MS, as you can see, if we plot the typical clinical course of MS with initial relapsing disease and some people developing then what we now call secondary progressive disease, that the idea was that because many people had these relapses from which they recovered, wait to see which patients were getting into trouble, and only then would you consider if the intervention with whatever therapy you had. At that time, the most intensive immune therapy was cyclophosphamide. So the idea was wait to see who got into trouble and then institute the therapy. And as all of you realize, how we have totally reversed the notion of getting into therapy as early as possible. So where did all this come from and how come this arose? And in many ways, we're fortunate by the advent of technology, both in terms of imaging and also biology. And I use it as an example, the story of interferon, and that it was in the late 1970s and early 1980s that the late Larry Jacobs was able to get a small amount of natural interferon and injected it into the spinal fluid, as you can see, of 10 patients with MS, and reported in Science magazine that there was an apparent effect of this therapy. That kind of number, and including at least one death that occurred in a patient from this therapy because of meningitis, this would not have led to widespread use of this approach. However, it was just about at this time that recombinant technology arose, and suddenly, instead of having a few drops of interferon available, we had unlimited amounts of this material. And in addition, this was just when the MRI arose, and I put in as an example of what did the MRIs look like in the mid-1980s. This was an early MRI given to me by my colleagues from then at the Massachusetts General Hospital. And if you had an MRI like this given to you now, you would say, I can't see anything. And yet we thought of this as a great advance. However, with the MRI technology and the recombinant technology, then one could carry out these large studies. Here, the pivotal trial having almost 400 patients, and one could show that there was a change in relapse rate, which was, you can see, relatively modest, but at the MRI level, there was a marked decrease in new lesion formation, and suddenly we were underway in the therapeutic era of multiple sclerosis. So what else did we learn from the lessons from therapy as we went along? And one of the major issues was MS, the same at all points in the disease course. And this is highly illustrated with our experience of anti-CD20 therapy, be it rituximab or ocrelizumab or one of the other anti-B cell therapies that we now use. And as you know, if you apply this to relapsing multiple sclerosis, there's a greater than 90% reduction in MRI activity if given early in the disease course. If you apply it to the later or progressive disease course, you have a much more modest impact of the therapy on this. For example, when rituximab was used for primary progressive MS, it didn't even reach statistical significance and required a larger cohort with ocrelizumab to do so. So clearly a major effect in relapsing MS and a modest effect in the later disease course, throwing out the challenge for us to understand what's the difference in the pathogenesis. So what have we learned over especially in the last several decades, about MS that can guide the developments for clinical care? And we can take advantage of observations that come from the clinic, from experimental studies, and as I mentioned, from therapeutic results. And from the clinical observations, we can consider the notion about where does MS occur and what are the underlying risk factors for development of the disease. And it's been known for a very long time that the distribution of MS worldwide is quite different from one part of the world to the other. But remarkably, this pattern has been changing, and that then raises the issue of the contribution of genetics and the contribution of environmental factors, particularly the latter, because of the changes that are being observed. An example of this is that it appears that people who move from areas in Asia to the West, such as from the Orient to America, that they have more of the Western type MS than in the phenotypes that used to be seen more frequently in the other parts of the world. The other is the observation that MS is occurring more frequently in females than in males. Whether the incidence of the disease is increasing is difficult to know because of the advances in diagnostic ability. An observation in the U.S., which for many years we were taught that the incidence of MS was mainly in the Caucasian population, the recent epidemiology studies indicate that it is the black females who have the highest rates in this community. So what about the genetics? And I think that we've known for considerable length of time that in monozygotic twins, the incidence of disease was somewhat in the order of 25 to 35% concordance rate versus 1 to 2% in discordant twins, that although the major link is with the HLA complex, that using modern molecular analyses, more than 250 weakly linked sites have been linked from the genome to disease susceptibility. And more interesting, perhaps, is that the identification of genes that are associated with disease progression are different than those that are associated with disease susceptibility, and they seem to point to either genes that have most relevant to cells within the central nervous system rather than cells from the systemic immune system. There is an overlap between MS and other autoimmune diseases, and this has raised the issue of, again, supporting that MS is an immune-mediated disorder, and of course we've taken advantage of this in our therapeutic attempts. What have we learned from the epidemiology of MS? And most recent, one would consider that perhaps amongst the risk factors, the observations related to the EB virus. As you all know, almost everybody by adulthood is affected, has been exposed to EB virus, but the studies that came from analysis of the American Army recruits has shown that if you can find individuals who have not been exposed to EB virus, that their chances of having MS are almost not measurable. So that it's almost a requisite that you have to be exposed to EB virus in order to develop MS. And this has led to the ongoing studies to determine whether this is related to, is there truly an EB virus infection that has resulted in cross-reactivity between immune cells to the virus and to some target in the brain, or has there been a dysregulation of the immune system in some way that allows an autoimmune disease to occur? And also a possibility that if there are only a small number of cells that are affected by the EB virus, do these, in fact, are they kind of the type of cells that can lead other cells to move to the brain and that collectively then result in the disease course? The challenge that's arising now is that if there was a vaccine that was effective against Epstein-Barr virus, would you immunize universally everyone, raising the issue of perhaps the reason that EB virus has persisted and its effects on the immune system, perhaps it has a protective effect as well. And so what is the risk if we immunize the entire population? Also arising over the last period of time has been disorders that previously may have been included under the MS umbrella, and now that we can distinguish. For example, neuromyelitis optica, which was considered under the MS umbrella, now has a very specific diagnostic marker that aquaporin-4 antibodies can be detected, a very specific disorder that now has a specific therapy involved. The other, which I think has received somewhat less attention and which one has to watch for, particularly in the progressive MS, is whether there are leukodystrophies. And again, Professor Singhal has been involved in the study of leukodystrophies over the years. That I show you examples on this slide of patients who've been followed in MS clinics with perhaps a typical course of neurologic disease that were considered MS, but were found to have very defined genetic disorders. So if we come back to MS itself and consider how does MS develop and how can we consider each stage in the course of MS? If we go back to Charcot, he pointed out that the impact of the disease seemed to be on this material that was coating the nerve fibers, which we call myelin. At his stage, they had very little insight into what myelin was doing, and they actually did not consider it to be very important, but they realized that that seemed to be the target. And even back then, from the outset, there was recognition of inflammation around the lesion site, so that there seemed to be this chronic inflammation. This was elegantly described by Dawson back in 1916. So as we moved forward, that from the biology side, that our insight into what was producing the myelin, what did myelin do, what about the cells that made the myelin, and again, summarized here, you can see that if you were in Charcot's time, myelin was barely recognized then. The nodes of Ranvier came afterwards. Identification of oligodendrocytes did not occur until the 1920s. And that it wasn't until the 1960s that definitively it was shown that the oligodendrocytes were the source of myelin that wrapped around the axons. And even now that we are finding more function of the oligodendrocytes, long-standing knowledge about its role in promoting saltatory conduction, but now we also recognize the metabolic support of axons provided by the oligodendrocytes. And importantly, there is now data that indicates that the number of oligodendrocytes we have are pretty constant as we go through life. There's very little turnover of these cells. Myelin is being turned over, so the cells are constantly having to produce more myelin membrane, but the number of oligodendrocytes is rather stable. So we have the oligodendrocyte, it's made its myelin, the myelin ensheiths the axons. What is the precedent that an immune reaction can in fact result in damage to this target and result in neurologic disease? And here we go back to the time of Pasteur, who developed this rabies vaccine that was made by extracting spinal cord that was infected with rabies virus, and the virus was inactivated, as we now recognize. And it turned out that a number of the people who were immunized with the Pasteur vaccine developed an inflammatory demyelinating disorder that one calls post-vaccination encephalomyelitis. And the animal model was created, finally, in which one could show that if you took neural tissue that wasn't infected, and you could immunize an animal as shown here, you could induce a similar disorder. This is referred to as EAE. And this sets the precedent that systemic activation of the immune system can result in cells trafficking to the nervous system and inducing a disease. And to this day, there still is a main focus on, is this the mechanism that induces multiple sclerosis? And this is illustrated on this slide, that this would indicate that MS is a disorder initiated by an immune response directed at oligodendrocytes or its myelin membrane. And because this comes from outside the nervous system into the nervous system, this is referred to as the outside-in phenomenon. Now, the alternate is perhaps there could be damage in the nervous system, and some of the damaged products would be transported back to the immune system, and that you get a secondary immune activation. There are some models for this, and this is being referred to as the inside-out hypothesis of multiple sclerosis. Now, do we have evidence of this immune process really being at the heart of the disease? And of course, here is some data that is highly supportive. This is from the experience of the group at the University of Ottawa in Canada, who did intense immunoablation requiring autologous stem cell transplant to rescue the individual. And here is these red dots here show the number of lesions these patients had prior to the treatment. And you can see after the treatment, there has not been any further clinical events or new lesions on MRI, indicating that you can ablate and probably induce immune tolerance so there are no more systemic immune events occurring. However, keep in mind that this intervention has not been effective for progressive forms of multiple sclerosis. So does multiple sclerosis meet the criteria for an autoimmune disease? We've tried to set up criteria for this based on modeling after infectious diseases, where you would show that there's a specific agent present in the target organ, and if you removed it, you had a therapeutic effect. And that the notion is, can you identify a specific antibody or cell-mediated immune response? And can you reproduce this in an animal model? And as this has gone on, this has been difficult to do in MS, but remarkably, we now have an increasing number of disorders, some of which were under the MS umbrella. And this, as I mentioned, neuromyelitis optica, and now log antibody disease, in which, in fact, we fulfill these criteria, so that of interest, we now have disorders that somewhat mimic MS, in which we've fulfilled these criteria, but in MS itself, we're still facing this challenge. And the other in MS, compared to these other disorders, why does MS take on the progressive form that it does? Can we show in actual MS patients that exposure to an antigen can induce exacerbations or induce multifocal brain lesions? We had, I guess, what one might call an unfortunate experience. We took part in clinical trials where we tried to desensitize patients by exposing them to an altered form of myelin basic protein peptide. The idea being, if you modify this peptide, that you could instead of getting an inflammatory response, you could get a regulatory response or an anti-inflammatory response, and you could actually potentially reproduce this in the modern era using mRNA vaccines. And so we took part in this clinical trial, as did the group at the NIH, and unfortunately there were one or more patients. You can see this is the pre-treatment MRI, and this patient developed 100 new lesions with this therapy. And so it almost set the precedent that yes, you could induce a systemic immune response going to the brain in MS patients. So what else have we learned from our therapeutic experience? That again, EAE is a T-cell mediated disorder, and there was a great deal of focus on T-cells and manipulating T-cells because EAE was a T-cell disease, and the pathology of MS suggested that MS was also a T-cell mediated disorder. However, we've known for a long time that you have a B-cell response or an antibody response, like the oligoclonal bands in the spinal fluid. And in some ways, we were fortunate in that when we tried to address what happens if you treated B cells, would that have a positive effect in MS? That, in fact, that the first attempts was because we had an anti-CD20 agent called rituximab available. This was used for relapsing MS, and as I mentioned, with a remarkable effectiveness. If you try to eliminate all B cells using inhibitors of B cell growth factors targeting what's called BAFF or APRIL, in fact, it made MS worse. And so, in some ways, I think we were fortunate in the MS field that we tried the anti-CD20 therapy before we did the pan-B cell directed therapy. And the other feature of the anti-CD20 therapy was the effects were so immediate that they occurred before there was any reduction in serum or CSF antibody levels. And this has opened up the entire field of how are these agents acting? Are they in fact acting by altering the immune regulatory networks, and more intense study ongoing on how to take advantage of such an event. Now, if we turn from susceptibility to disease course, that we should know that there is a difference along the different disease course of MS. If you look at the pathology, the acute lesions with the highly inflammatory lesions, the more chronic lesions with the microglia macrophage rim, and the chronic lesion that has very little activity ongoing. So that you would think that there should be different types of problems contributing to the disease course. So in the early case with the inflammation, what does this early inflammation do? And that with these lesions here that are expanding, what's the mechanism that allows these lesions within the brain substance? And then the important issue that you see along the ventricles, along the disease concentration, indicating the issue of whether products in the spinal fluid and along the meningeal surfaces are contributing both to the periventricular lesions and the gray matter demyelination that is increasingly recognized in MS. So with our colleague Tanya Coleman in Germany, we set out to look at the status of the oligodendrocytes in MS, and Tanya, with her wonderful work, showed that relatively early in the disease, the oligodendrocytes are relatively preserved, but then are lost over time. Now, in our basic work, what we do is we isolate oligodendrocytes from human brain material, put them in tissue culture, and we can check whether they are vulnerable to injury. And yes, we can define a whole series of CD8 cells and non-antigen restricted T cells, CD4 cells, NK cells that are capable of damaging and being cytotoxic to oligodendrocytes. However, we are more considerate of this pathology that was defined by the late Sam Leibler experimentally and with Moses Rodriguez in MS tissue, where the oligodendrocyte cell body is preserved, but the processes are being affected. Very much for those of you who work with peripheral nerve, the notion of a dying back phenomena. So a sublethal injury of the cell body, but an effect on the processes early on in the disease. And this is summarized here. And we found that if we put many inflammatory agents or glutamate, we get this sublethal injury of the cells. If we put the cells under metabolic stress, then we can get them to go on and eventually die. And in the elegant work done by people like Hans Lossmann, who've shown that the MS microenvironment is very much an ischemic environment with metabolic stress reagents present, and we think this is a very important component that contributes to the progressive loss of oligodendrocytes over time. If we go back to the clinic and look at MS patients, that as reported by Fred Lublin and his group and others now, that although early on the relapses contribute to disability, over the course of time, the major accumulation of disability reflects progression in absence of relapse activity, which has been referred to as PIRA. So what is causing this continued progression without these new lesions? And as I was mentioning, we have to consider that progression of these existing focal lesions and expanding, and we also consider very much that the development of these subpial lesions and periventricular demyelinating lesions may reflect either the products that are present in the spinal fluid accessing the parenchyma, or that a variety of cells are present in the meninges and overlying the meninges, and they again exert this harmful effect on the underlying cellular structure. So we have a combination of events that of ongoing injury that can contribute to the continued progression. Now, the flip side of that is why isn't there a repair? If you look at cases, for example, of mild antibody syndrome, here's a case that we had where we actually biopsied the lesion, showed there was demyelination. Here's the follow-up, and you can see the repair. So certainly there's capability of repair in the central nervous system. If you ask why do you not get this repair, you can show that the variables include early lesions have more of the repair, younger patients have more of the repair. As shown, this was an in vitro study where we took the oligodendrocytes from adults and from children and compared them, and you could show that pediatrics were better at ensheathing nanofibers, and that also gray matter cells did better than cells from the white matter, shown here. At the bottom here illustrates how we put our cells onto artificial nanofibers and can look at ensheathment in vitro. And doing this, we can see that now we can go at molecular properties of the cells and see what is the difference between pediatric and adult gray matter versus white matter, and see whether we can find pathways that could be therapeutically targeted. In this modern era of single-cell sequencing, if you take oligodendrocytes, you can find that there's a heterogeneity in this population, and again, the challenge to find the critical pathways that could be targeted and could they be used to promote remyelination. So in terms of what our insights have taught us and where it guides us for future of clinical care, one is paying attention to prevention. I mentioned the EB virus ongoing studies, a number of other risk factors, vitamin D, smoking, and how important, so these would be for actually reducing the disease severity. Early diagnosis and effective treatment has now been shown to be a very important issue, and the data has now clearly emerged that if you reduce injury early on, we will delay the entire course of multiple sclerosis. I mentioned that we increasingly found that there are the MS-related disorders and mimics the genetic disorders and some of the autoimmune disorders that I mentioned, such as NMO and mild antibody disease. So with this in mind, we still are facing that we have many patients who have this progressive disorder. How are we going to intervene and help? And what we have to be thinking now is, do we have agents that can be directed at the CNS compartment and take advantage of going after the immune responses and the glial components? And I will talk more of that in my second presentation. But we now are starting to have the first generation of drugs that access the central nervous system and can be directed here. Can we protect cells from injury, and can we promote remyelination? That is currently there are limited studies on repair for remyelination, but these are about to come underway. So that I think that I hope that I've been able in the last few minutes to describe to you some of what I consider major advances. Clearly, we've made a difference in the course of multiple sclerosis. We've identified new entities, and now we throw out that we have the challenges still of ongoing protection and repair to deal with. Again, I would like to thank you for inviting me to give this presentation, and I want to again express my thanks to the organizers and especially express my admiration to Professor Singhal, and thank you all very much.
Thank you, Dr. Ankel. Is he there online? Has he joined? Vavish? Yeah, hello. Dr. Singhal is there? Hello, sir. Can you hear me? You're muted.
Professor Singhal sir, kindly unmute yourself.
Sir,
Professor Singhal sir, kindly unmute yourself.
thank you. Just say thank you. Then. Just say thank you. Thank you, sir. You both are talking to. They can hear each other. Yeah. Okay. Sir. I know. Good gift.
This is really a progressive component of these disorders.
Thank you, sir. Thanks for the wonderful oration, and I think we will be sending over the flag to your place somehow. And I'm sorry we couldn't. I wish you were here to receive the plaque, oration plaque.
Thank you for that comment. I wish there was a non-stop flight between our two cities.
Thank you, sir. Thank you, Dr. Singhal, for joining us. Thank you so much. Yeah. So no, we don't have questions in the oration, sir. No questions for them. Yeah. Thank you, sir.
Thank you, respected sir, and thank you, our honorable chairpersons, for that session. Truly, knowledge knows no physical boundaries. Thank you again for that marvelous session through the screen.
And after that incredible display of knowledge, we would now continue with yet another moment of prestige, the IAN oration led by Professor Dhairyawan.
Let us lend our ears and our hearts for our upcoming talk that will inspire narratives and make us remember that science is not only about discovery, it is also about perseverance, empathy, and humanity.
I request our chairperson, Professor Dhairyawan, to please come on stage for our next session.
Ladies and gentlemen, please put your hands together.
Hello. Good morning, ladies and gentlemen. This is a very prestigious oration and oration. You know, I was president when IN was formed, and I have seen this organization grow, and we also grew with it. And today, the IN oration, the prestigious oration, is going to be delivered by Dr. Mohit Bhatt on a very important topic about his experiences, about Wilson's disease, how he explored, and he's going to share his thoughts. And I request Dr. Mohit to come out to the dais and deliver his oration. As this is oration, there will not be any questions. Dr. Mohit will love to interact with you off the stage.
I'm going to introduce him. Yeah. Anyway, it's indeed good morning, everyone, and welcome to the IA in Oration 2025. It's indeed a matter of great pride, pleasure, and personal satisfaction to be introducing a person who is very close to heart. And I promised Mohit that I'll talk only good things about him. So, and that are only good things. I'm just joking. There can't be anything bad about a person like Mohit. Dr. Mohit Bhatt is a senior neurophysician, the director of neurosciences at the Kokilaben Dhirubhai Ambani Hospital and Medical Research Institute, Mumbai, where he has been associated for the past 2 decades. He is recognized for pioneering the field of movement disorders as a subspecialty of neurology in India. Dr. Bhatt is credited with several firsts: the therapeutic use of botulinum toxin for dystonia, DBS as an interventional modality for Parkinson's patients, and establishing a state-of-the-art clinic for Wilson's disease in India. The first, until today, the best referral institute for Wilson's disease, along with conducting groundbreaking research. With more than 150 publications in reputed journals, he has dedicated over 3 decades to popularizing movement disorders in India and internationally through numerous lectures, seminars, and conferences. Dr. Bhatt has been a mentor and guiding force to many young like me and established neurologists within the fraternity. That's a formal introduction, and I would really to know Mohit as a man too. He's a man of style. I was a resident 32 years ago. He had just come back from his training and he had just started the movement disorders. And I still remember that he had come to Madras Medical College along with Niyal Quinn. And I was so impressed the first time, all of us, stargazing, we did it Mohit. And Mohit as a personality, sharp but a very sweet dynamite he is. He has such wonderful clinical knowledge he gave us that time. I'm sure that I have no hesitation in saying that this is one of the earliest reasons that pushed me into movement disorders too. Thank you, Mohit, for that. And even at that time, ladies and gentlemen, he had a Mercedes Benz. So when I was driving a Hero Honda, so I knew how big a neurologist can be if he is as dedicated and works hard. So thank you for setting the example, my dear friend, and the stage is all yours. Ladies and gentlemen, please welcome Dr. Mohit Bhatt.
I want to this is, so can I, well, so I want to thank IAN for inviting me for this prestigious talk. I feel humbled and honored to deliver a talk on my journey with Wilson disease. Thank you, Sangeeta, for inviting me. And Meenakshi, as usual, big thanks to you for that introduction. So I'm going to, in the next 30 minutes, take you through my journey with Wilson disease. The reason I selected this topic is that I was interested in Wilson disease earlier in my career. And as time passed and I started looking at Wilson disease, and when I was with the first patient, I realized I really don't know how to treat the patient, when to start drugs, how much drugs to give, and the problems that happened. And as I started looking at
Wilson disease, reading about it, and then slowly started publishing, that brought in more invitation to lectures, more invitation for travel, where I learned more and more about Wilson disease. I started publishing more, reading more, and I realized that there was a whole sea of knowledge and information to be gathered. And that got me more and more interested in Wilson disease. So what I've done is, I'll take you through all the developments that I witnessed as a doctor
with Wilson disease. So it all starts with S.A.K. Wilson. S.A.K. Wilson was a neurologist who published this paper in Brain, and this was a single issue of Brain. The whole issue was dedicated to his paper, and it is basically, he showed lenticular degeneration with cirrhosis of the liver in a familial setting. By the age of 30, S.A.K. Wilson was a very famous neurologist. He had described a disease which a lot of people didn't know existed. So he became a very important neurologist in the UK and the world over. S.A.K. Wilson was a true first movement disorder doctor. He was a man who introduced the word extrapyramidal nervous system. Till then, we always spoke of pyramidal nervous system. He is the one who said that there is something called extrapyramidal nervous system. So the whole concept of extrapyramidal, he's the guy who started videotaping his patient, and this is one of his patients of Wilson disease with a tremor. This is called pseudosclerotic variety of Wilson disease, and you can see the tremor in this girl, the facetious smile, and the tremor increasing with isometric contraction. And here you can see this he filmed outside Queen Square Hospital. The patient is bedbound, he is wheelchair bound, and you will see he has a drag on the right side. And there is that man standing. My gut feeling is that is S.A.K. Wilson. And this is outside Queen Square Hospital. So this was the first patient he videotaped. And after his death, these films were lost. And S.A.K. Wilson was friends with Charlie Chaplin. So Charlie Chaplin said that, hey, I know somebody in Kodak studio. Why don't you ask the Kodak people to make the films for you? So these were made original films by Kodak studio, and that's why you can see they are such high quality, even though taken in 1912. He documented patients. He showed photographs of patients, how they deteriorated. You can see the dystonic hand, the open mouth, the dull face of Wilson disease. So he documented patients' clinical symptoms, the change in handwriting with Wilson disease, so deterioration in motor function was documented by him. So he not only examined patients carefully, he looked at their clinical symptom signs, videotaped them. His singular interest was neurology, and he did post-mortem examination of his patient. If he had a patient who would die in another city, he would fly into that city to be present at the time of the post-mortem. And here you can see the degeneration of the basal ganglia, and he also showed that there is cirrhosis of the liver. And S.A.K. Wilson was the first man who said that the liver gets affected before the brain. And now we see this Wilson disease, the facetious smile. This is the smile that gives you the diagnosis. When you see this in young kids, the smile, mixed movement disorders, as you can see in this girl, she's trying to speak, has a Parkinsonian gait, dystonic hand, two movement disorders. This is Wilson disease. So this is a clinical disease that we all see in our practice. And he uh, in his paper, he wrote that if physicians familiar with the disease can readily recognize this, and this is exactly what happens when you start seeing patient with Wilson disease, multiple patients, and you pay attention to their clinical signs. The next time a patient walks in, you will diagnose him very fast. So one has to be familiar with the disease, and that's what S.A.K. Wilson did. And then soon it was known that Wilson disease is an autosomal recessive disease, and it was due to excessive copper deposition. So we know that Wilson today, everybody's common knowledge that Wilson disease is because of copper. And here Cummings showed that there is excessive copper in the basal ganglia, there is excessive copper in the liver, and so Wilson disease from a degenerative disease became a mineral metabolism disease, which was autosomal recessive and was fatal. And that's exactly what happened, that all patients with Wilson disease were invariably dying. There was no treatment for Wilson disease till the 60s almost, till Sir John Walsh came into the picture. This is a man who discovered penicillamine. He discovered trientine, the liver transplant, the bowel treatment for Wilson disease. So personally, I feel that the Nobel Committee should have given him a Nobel Prize for medicine. Today, there are people hankering for Nobel Prize, but I think this man truly deserved a Nobel Prize for medicine for discovering 4 or 5 path-breaking treatments for Wilson disease. And that's what happens with copper. When you have copper in your food, through the GI tract, goes into the liver and is excreted into bile. So this is the story of copper in normal people, you and me. And when we eat food, we don't think that, kitna copper hai khane mein? Have we taken enough copper? You don't think. Because copper homeostasis is beautifully maintained. And if you have deficiency of copper, you die in the first 2 years of life. So copper is required for all metabolic pathways, all intracellular metabolic pathways, mitochondrial function, scavenging function, dopamine production, neurotransmitter production. Copper is essential. If you don't have adequate copper, patients die in the first 2 years of life, and so in normal life, you really don't need to worry about copper because the body works so beautifully that what copper you ingest is excreted and you have copper homeostasis. Now in Wilson disease, now we know that it is an autosomal recessive disease, and it is because of ATP7B gene mutation. So ATP7B is a protein that is there in our liver cells. And you get 1 copy from the father, you get 1 copy from the mother. And if those 2 copies are abnormal, then you have mutation in the paternal gene and the maternal gene, and you develop the disease, which is autosomal recessive disease. And that leads to 3 organ problem. You have a liver problem. Here you can see fleeting jaundice, hemolytic anemia. You can have brain involvement, and you can have osteomuscular involvement. There are very few diseases in the body which affects the brain, the liver, and the osteomuscular system. So if you have a patient with these 3 systems involved, clinically you can diagnose Wilson disease very confidently. You don't really need lab support. And the challenge is diagnosing Wilson disease. As you can see, that this girl lost 2 brothers to Wilson disease before her diagnosis of Wilson disease was made. So it is not uncommon in a family with Wilson disease to have loss of 1 child to Wilson disease before the diagnosis is made. And 75% of patients with Wilson disease go undiagnosed and die. So even today, Wilson disease is a big challenge in the diagnosis. And here you can see the boy has symptomatic Wilson disease and needs treatment. But the little sister is asymptomatic. Now the challenge is that we have to treat both of them so that the boy becomes normal and the sister never develops symptoms. And the challenge is that Wilson disease is a lifelong treatment. When you take on this family, you are not going to treat them for 1 month, 2 months, for 2 years, but you have to treat them lifelong. Wilson disease treatment never ends. Even if the patient is asymptomatic, they have to be treated so that they never become symptomatic. And so that is the challenge. How do you convince them?
How do you convince kids to take tablets? How do you convince a family that asymptomatic member needs treatment? So that's a challenge that we take on as doctors when we take on a family with Wilson disease. So diagnosing Wilson disease is an important thing. And a lot of patients go undiagnosed. So first is you identify the neurological disease. If you get the neurology phenocopy, then you say that is it a multisystem? Is the liver affected? Is the bones affected? And then is it a familial disease? So if you can establish these three, chances of diagnosing Wilson disease gets easy. So just let me walk you through what neurology is all about. Neurology can be, as you see in patient 1, has a rubral tremor. He needs support to walk. Axial involvement is very common. Patient 2, you can see his marked gait problem. This is 2 years after treatment. He was bedridden when I inherited him as a patient, and today he's just started walking. And this is a sign, handkerchief sign. They invariably drool. So they all have a hanky in their hand. So marked oromandibular movement with axial involvement. And here you can see mixed movement disorder. This boy has got stereotypy, but he has dystonic hands. He has an open mouth. And you see that smile, that it's facetious smile in Wilson disease. This girl has got chorea. She is wheelchair bound. And the third boy has dystonia. So I want to show that you can have a play of involuntary movements, severe dystonia, mouth open dystonia. So these are the different neurological, but the common thing is that they have oromandibular movement involvement. They have open mouth. They have, and not only is involuntary movement, but they also have behavioral problems. This is a boy who is tapping the nurse in the corridor, arguing. Patient 2 has written a confession about his behavior. Patient 3, utilization behavior, waiting outside the OPD. So when you have a combination of movement disorders, behavioral problem, or a various proportion of it, facetious smile, open mouth, dull look on their face, and Kaiser-Fleischer ring, that's the neurology of Wilson disease. You need a torch to diagnose Wilson disease. And if you have this combination of neurology, KF rings, and then you go to the next step. Is the liver involved? Is the osteomuscular system involved? So liver is usually, by the time you have a patient with neuro-Wilson's, he has neuro-Wilson, patient has already got liver involvement. So liver involvement happens almost 10 years before the brain gets involved. So they can have fleeting jaundice, hemolytic anemias, or sudden liver failure. So all patients must have an ultrasound and a liver function test in a suspected case of Wilson's, and bone involvement. Osteomalacia, proximal muscle weakness, bony involvement, bony cysts. So if you have a combination of this, then you go to the next step. The next step is it is a familial disease. So is a family history of Wilson disease. Is there a sudden death because of Wilson disease? Is there an unexplained liver disease or a mutation analysis to confirm? So when you have these three, you have a clinical diagnosis of Wilson disease. This is called pattern recognition. You need to recognize this pattern. You don't need to worry about tests. This is more or less certain Wilson disease. If you do the MRI scan, you will find abnormality on the MRI scan. Caudate, putamen, thalamus involved, brainstem involved, and sometimes white matter is involved. So Wilson disease is so easy to diagnose clinically with an MRI. But I see a lot of energy spent in doing lab tests. If I have a patient with dystonia, he will have ceruloplasmin. Patient is young onset Parkinson disease, you have ceruloplasmin done. You don't need to keep a Wilson disease a diagnosis of exclusion. It has to be positively diagnosed because it has certain symptoms and signs, it has certain manifestations which you need to recognize and then diagnose Wilson disease. So patients, I see lots of reports of ceruloplasmin, 24-hour urinary. I have not done a single patient 24-hour urinary test, and I look after 450 patients with Wilson disease. So we don't do 24-hour urinary test, the most bogus test. We never will with the dry weight of the liver. You will be able to diagnose Wilson disease clinically. And ceruloplasmin can be very deceptive. You can have high ceruloplasmin with liver inflammation. If you are a carrier, you get one gene from the father, one from the mother. If you have a single gene disease, then you will be a carrier. You will have a heterozygous variety and you will have slightly low ceruloplasmin. That is not Wilson disease. That does not require treatment. So what is the basic pathology in Wilson disease? It is the ATP7B protein, and that protein sits in the hepatocytes in the endoplasmic reticulum. From the endoplasmic reticulum, this protein goes to the Golgi apparatus. This is the protein that is abnormal in Wilson disease. So this is what happens when copper comes into the cell. 6 molecules of copper will get attached to ATP7B protein, and that protein takes the copper and gives it to apoceruloplasmin as a gift, and which forms ceruloplasmin. So ceruloplasmin is just a courier. It carries copper on its shoulder and takes it out of the cell and moves around with copper. It has nothing to do with Wilson disease. So you have low ceruloplasmin because your ATP7 protein is abnormal, and so it is not forming ceruloplasmin. Ceruloplasmin has no other role to play. So it's an incidental test. Most of the copper gets attached to ATP7B and is excreted in bile. So if you have an abnormality in ATP7B protein, you are going to get Wilson disease. It has nothing to do with ceruloplasmin. So don't be excited about doing ceruloplasmin. Ceruloplasmin, yes, it helps, but it's not the biggest thing. And so that's the ATP protein gene. It's a 21 exon gene, and the photograph down is the actual protein. And you can see the 6 copper domains where the copper molecules are attached. So this is 14 mutations that we described in ATP. Today there are more than 600 mutations. So doing a genetic test is very cumbersome and very difficult and very expensive, because if you have to find a mutation, but certain regions have a certain mutation. So if you know what is the mutation in your region, then it's easy. Like the map of India, we have mapped out common mutations from different regions of India. So if your patient comes from a certain region, you only do mutational analysis for that region, and you may probably have a higher chance of diagnosing genetically Wilson disease. And the world map also now has common mutations in different countries, different regions. So that's all available. So monitoring is very important. When you have a patient with Wilson disease and you start treatment, you really don't know whether the patient is doing well. Is the patient improving? He comes back to you after 2 months. The mother says, he's a bit better. You don't know whether he's better or not. So the commonest problem with Wilson disease is that patients have low compliance with medicines, and doctors are afraid to give drugs. So they are under-medicated. And this is data of 100 patients whom we inherited. And when we analyzed, 60% of them were under-medicated, suboptimal treatment, stop treatment in between. Only 7% were on adequate treatment, and almost 35% of patients were drug naive. So you can imagine only 7% the rest are all requiring treatment. But treatment works. It's wonderful. you have to have faith and you have to treat them. And you can see that if you get good treatment, everything goes away. And there are multiple publications that we have published on treatment of Wilson disease. So those who are interested can get these publications. We have a fairly detailed analysis of how to treat patients. So treatment, low copper. Low copper is not needed diet. You can give normal diet to kids with Wilson disease, provided you are chelating them properly. If they're getting proper treatment, low copper diet, so don't touch the kids. There are 3 drugs here, zinc, penicillamine and trientine that are used for Wilson disease, and thiomolybdate and British anti-leucite agent. So of these drugs, there are 2 drugs that we dominantly use, penicillamine and trientine. Zinc is rarely used. I see most patients have a combination of zinc and penicillamine. The zinc is blocking your penicillamine, so your patients will never improve beyond a point. So using zinc with penicillamine is not a good idea. So the first thing that I do when I see a patient is that I remove zinc. Do not use the 2 drugs together. We rarely use zinc. And that is that is Walsh, the gentleman on the left, in his 90s, and he died recently. Till his death, he was publishing papers on Wilson disease. And that is S.A.K. Wilson's grandson. So S.A.K. Wilson, after he died, his films were lost, and his grandson one day woke up and said, "Hey, I have some videotapes of my grandfather lying in my attic." And that is the videotape that I showed you, which was lying with S.A.K. Wilson's grandson, and they were re-archived and published in the Movement Disorder Journal. So this was a challenge. We have an asymptomatic little girl who needs to be treated so that she never becomes symptomatic. And treatment of asymptomatic Wilson disease is a big thing. So Scheinberg and Stoneleaf were 2 very big authorities on Wilson disease in America. And they published this paper of giving in NEJM treatment for asymptomatic Wilson disease. When that paper went in, it had 53 patients and they said that we don't need to take controls because controls would not get treatment, and this is a fatal disease. So we can't not treat the controls. So 4 clinicians, 2 epidemiologists, and 3 statisticians rejected the paper. One of the editors from England flew to New York to confront one of the authors. That big the controversy this paper had raised. It went through 3 revisions, and the papers were rejected every time because it did not have controls. In the end, the chief editor said, "It is high time to publish this manuscript. Critical reader must decide for himself." And lo and behold, today, asymptomatic Wilson disease treatment is the standard treatment, and now it is an established treatment. So you can imagine how difficult it was at that time to establish treatment for asymptomatic Wilson disease. So the one slide that if you have to remember, this is the slide. Wilson disease treatment is given either penicillamine or trientine 3 hours before meals. I usually see patients taking after breakfast, lunch, and dinner. The drug is absorbed less than 50%. So the kid gets up at 5 o'clock in the morning. He takes all his pills. If he's taking 5 pills, he swallows 5 pills one after the other. And breakfast comes at 8 o'clock. Or if you want to give it 2 times, then the dinner at 7, at 10 o'clock, the pills come. There has to be a gap of 3 hours from food for maximum effect of penicillamine and trientine. So when I have a patient who's taking multiple pills 3 times a day after meals, the moment I give him like this, I drop the dose 50%. And that's the effective way of treating these patients. Side effects, all drugs produce side effects. Penicillamine, trientine, they have side effects. But that's why doctors are made. It is our job to look after these patients. It is our job to take them through all the problems of Wilson disease. You can't casually say that, okay, take these tablets of penicillamine and you will be okay. It won't be okay. There will be problems. The cells can fall. They can have nephrotic syndrome. They can get a whole range of neurological problems with Wilson disease treatment. But that's what is the challenge, and that's what you need to do. When you take on Wilson disease, you really take them on as a doctor. And to see whether my patients are doing well or not, this is a classification we created. Today, this is all centers of Wilson disease in the world over use this classification. It's a classification which is published in the Movement Disorder Journal in the classification section. And it's a classification to measure Wilson disease disability. So the first is tier 1. It measures liver, cognition, motor, and osteomuscular system. And tier 2 measures 14 neurological items. You can't add that because there are different systems in the body. But you can add the neurology, the 14 item, the total score is 54. So if you score something like 25 and above, you have pretty bad Wilson disease. Usually patients do not score more than 30 because these are bedridden Wilson disease patients. And we also score their faces. We also score Kaiser-Fleischer rings. So this is the unique part of this classification. And that's how the classification looks. So every time a patient comes, he has to undergo the classification to know what is the disability. And you can see that a patient has come multiple times and the dates are written on top. And it gives us a measure of change. Is it improving? Is it deteriorating? And this is a very sensitive classification. If a patient stops treatment for 2 months, the classification will reflect deterioration. So this is a very sensitive classification. So it's a very useful classification. And every time patient comes, we do 2 tests. We do CBC and liver function test. I want to know if the liver is deteriorating. I want to know if the counts are falling. As you can see, none of the patients have had one ceruloplasmin. We don't do 24-hour urinary copper. Probably we don't do any other test. These are the only 2 tests that we do when a patient comes. I don't think there's a need for anything else. So I'm simplified investigations for Wilson disease. And I'll walk you through this patient. This is a boy. He's drug naive. His score is 29 on our classification. And look at him. He has got dystonia of his toes, his limb dystonia, and that's how he walks. He's carried by his father. He can't walk. He's lost the ability to walk. And here he is 1 year later when now he is on 2 grams of penicillamine and his score has dropped to 17. And you can see the smile that has come on his face. This is the facetious smile of Wilson disease. You can see his toes are badly injured even now after 1 year. But in 1 year's time, he has started walking. So if you and here he is 2.5 years later, we have now de-escalated to 1 gram of penicillamine and he has started running. So it can be very gratifying. It's a slow process. It takes 2 years. A bad Wilson disease, you tell the parents, take the kid off school, let him be at home for 2 years. This is going to take time. But if you pursue it, continue with medication, most kids will improve. Pregnancy, you can have children. This is a lady with Wilson disease. This is her baby. The only thing is that you can't lactate. Lactation is not allowed with chelation. And during pregnancy, you drop the penicillamine trientine dose by 50%, but otherwise the drugs are safe. So you can use the drugs during pregnancy. And what improves? Handwritings improve, motor skills improve. The scholastic performance. I have boys who are in IIT doing medicine after diagnosing Wilson disease and under treatment. Behavior improves. You can see the faces, the dull faces have now become bright. So the dullness on the face goes away. Platelet counts improve. And growth spurt takes place. They start throwing on. So we measure their height. We measure their other parameters. Once they start improving, girls start getting their periods. Once that happens, you know you are on the right track. And the problem with Wilson disease is non-compliance. And this
patient whom I had seen at the JJ hospital. Her score was 33. Look at her. She got severe pseudosclerotic variety of Wilson disease, Riles tube, bedbound, severe tremor. Her tremor was so bad that we had to tie her legs, otherwise she was hurting herself. Severe tremor of Wilson disease. And this is in 23, the same patient, fantastically better. No neurology, improve. So you can improve to this extent. But a lot happened in between. In 2012, by 12, she had complete remission. She got married, she had a baby, everything fine. And she said, well, I'm fine. Why should I take drugs? So she stopped drugs. 10 years later, her tremor came back. First video, just see that. Now she's become tremulous. And she realized that I've got the disease again. So she started penicillamine on her own. She'll become tremulous. And her score was 20 on the global assessment scale. We increased slightly, 250 milligram, because we knew that she will continue to deteriorate and tremor worsen. We increased the medication because we knew we had to chelate her. She had not taken drugs for 10 years. And you can see the tremor is still there, but slightly better. And then by July, you can see the tremor is there. She continued with 1000 milligrams, then further escalated the medication slowly. And you can see that she has improved markedly. And here she is in 23, again a second remission. So non-compliance, this girl stopped because she was doing well. So educating the patient that not to stop medication is very important. And non-compliance is a very big issue. These are different publications showing that penicillamine triantine works. So another thing is worsening. Most neurologists are worried that patient will worsen with treatment. And this happens usually if you chelate them fast. So this is a boy at the JJ hospital. Score was 24. In the first 1 month, he received 3 tablets of penicillamine. And you can see he was dystonic, but now he looks unhappy. He is bedridden because his sudden increase in chelation can lead to neurological worsening. He's lost speech, can't speak, can't sit, and needs to be helped. Then we de-escalated the treatment. And you can see the speech has come back. And in 6 months' time, he started walking again. So sometimes sudden, so the thing is that go slow, start slow. We usually go from first dose to the second dose after 2 months. We do not increase even if the child is doing well, because if you suddenly give him more, the patient can deteriorate. So the take-home message is Wilson disease diagnosis is often delayed, patients are under-treated in most cases, and treatment is not adequately monitored. So high degree of suspicion, copper chelation can reverse all neurology. So you have to try till patient becomes normal. You have not ended till your patient is not normal. And close monitoring is very effective. Both triantine, penicillamine are effective drugs. So there's nothing to select between the two. They have same side effects. Nothing to select on side effect side. Both drugs to be given fasting. If you are using any one of them, 3-hour fasting. And usually we give all drug tablets together. We do not use zinc with penicillamine triantine. We rarely use zinc. Adequate chelation. Inadequate chelation is the commonest cause of disability. Cirrhosis. Cirrhosis is the most stable cirrhosis. So if you have a patient with cirrhotic liver, do not worry. If you chelate them well, that cirrhosis will remain lifelong. Patient will not get portal hypertension. Patient does not need liver transplant. Liver transplant is an emergency. Liver transplant has high mortality. So you have to be very sure you want to transplant a liver. So try and treat patients medically and they will be okay. Close monitoring with global assessment scale is very important. And 15% will have residual neurological deficit which you can't control. 24-hour urinary copper testing is a useless test, don't do it. CBC and LFT are the only two tests that we do regularly to monitor. And this is a little girl who got Wilson disease. 2 brothers died. And now here she is, 14 years of age, completely normal, asymptomatic, on 1 tablet of penicillamine. So treatment is gratifying. There are lots of people who have helped me. Dr. Anu Agarwal, who is my colleague, runs the Wilson disease OPD with me, done a lot of work, lots of research fellows, residents. We have collaborated with a German university for the genetic workup. So over the years, people have helped us do this work, and I want to thank IAN for inviting me for this oration. Thank you so much.
Thank you, Dr. Mohit, for your very excellent lecture covering almost every aspect of Wilson's disease. Though I was thinking that incidence is coming down, now you have informed me that it is the same. And I request Dr. Meenakshi to sum up and continue the proceedings.
Thank you, Dr. Mohit, and as usual, a master class on Wilson's disease. Thank you very much. It's a pleasure to honor you. Please come.
Thank you so much, dignitaries. Now, as the clock strikes 12:30, we will transition to guest lecture 1, where the mysteries of motion meet the marvels of imaging.
Let us listen from our experts and our esteemed chairpersons, Dr. Debashish Chaudhary from New Delhi and Dr. Achal Kumar Srivastava from New Delhi to guide us through the unseen pathways of the brain and start our next lecture.
Honorable chairpersons, we kindly invite you on stage to begin this session. Thank you, dignitaries. Honorable chairpersons, again, Dr. Debashish Chaudhary and Dr. Achal Kumar Srivastava, please kindly come up on stage to begin this new session.